Hello everyone and welcome to our module on torch infections. The torch infections are infections that can occur in a mother during pregnancy, and when they do, they lead to poor fetal outcomes. For example, torch infections can lead to miscarriage or stillbirth. They can also lead to a number of fetal anomalies. And they're called torch infections because this is a mnemonic for toxoplasmosis, other rubella, CMV, and herpes. And so we'll go through all of the different potential torch infections in this video now. Let's start by talking about Toxoplasma gondii, which causes toxoplasmosis. This is a protozoal infection that commonly lives in cats or felines, and cats shed oocysts of the protozoa in their stool. Humans can be infected if they ingest oocysts, which can be found in soil. They're also found in the meat from contaminated animals. You can also sometimes find oocysts in raw shellfish. When a mother is exposed to toxoplasma in pregnancy and develops a primary infection, usually she will be asymptomatic. In immunocompetent mothers, 80 to 90% of infections are asymptomatic. When symptoms do occur, they're usually nonspecific symptoms, things like lymphadenopathy or fevers, chills, and sweats. Now, after primary exposure, a latent form of toxoplasma infection can occur, and the protozoa can lie dormant in the body for years and years. But you should be aware that latent infection usually does not cause problems in the fetus. It's only if the mother develops primary infection during pregnancy that fetal complications can occur. When the baby is infected in utero, usually they will appear normal at the time of birth, although they are at risk to develop symptoms later, including long-term complications like intellectual disability. There is, however, a classic triad that occurs in a minority of infected babies, and that triad is hydrocephalus, chorioretinitis, which is inflammation of the choroid in the eye, and intracranial calcifications. And this last finding, intracranial calcifications, is often identified on prenatal ultrasound imaging, and when this is found, it's often an indication to do antibody testing on the mother to see if she has a toxoplasma infection. In order to prevent development of toxoplasma infection in pregnancy, pregnant women are advised to avoid raw or uncooked meat and raw shellfish because these foods could contain oocysts. Women are also advised to wash or cook fruits and vegetables which may have been exposed to contaminated soil. And then if women have a cat, they should avoid changing the cat litter during pregnancy. We don't usually screen for toxoplasma in pregnancy because there's a low prevalence of this disease in the US. You should consider testing anytime the mom has a febrile illness or if there are abnormal fetal ultrasound findings like intracranial calcifications. The diagnosis of primary infection can be made through antibody testing. IgM antibodies are positive in the first week, and IgG antibodies are positive after that. They peak at about 6 to 8 weeks. And then they fall over the next 2 years. When primary infection is identified in the mother during pregnancy, she should be treated with antibiotics. The drugs that are often used are either pyrimethamine sulfadiazine or a drug called spiramycin. Spiramycin is rarely used in the US. Its one main indication is for treatment of toxoplasma in pregnancy. At the time of birth, the baby is also treated with antibiotics. Usually babies receive pyrimethamine sulfadiazine, and this drug can disrupt folate metabolism in the baby, so usually leucovorin is given as well. Next, let's talk about rubella. Rubella is caused by an RNA virus, and primary rubella infection in a mother is usually a mild self-limited illness. The classic finding is a maculopapular rash, like what's shown on the screen here, plus other nonspecific features like lymphadenopathy and joint pain. The main danger of rubella infection is not to the mother, it's to the baby, and that's why we vaccinate against this virus. So rubella infection in pregnancy can cause intrauterine growth restriction or fetal demise. And when infection occurs in the first trimester, there's an 80% risk of transmission to the fetus. And this is where most of the problems in the baby occur when first trimester infection develops. Major fetal effects are rare if the baby is infected later in pregnancy after 20 weeks. When fetal infection occurs, if the baby survives until birth, the baby can develop the congenital rubella syndrome. Clinical features of this syndrome include sensorineural deafness, this is a form of congenital deafness, plus congenital cataracts. Cardiac malformations are also common. The classic cardiac defect is a patent ductus arteriosus. These babies can have purpuric skin lesions. This is a finding called the blueberry muffin baby. This occurs when hematopoiesis develops beneath the skin in babies with rubella syndrome. And then you can also see other features like microcephaly, long-term intellectual disability, and autism. If a pregnant mother develops a maculopapular rash like this in pregnancy and you suspect rubella infection, the diagnosis can be made by testing for rubella IgM or IgG antibodies, or in some cases viral culture is done. Unfortunately, there is no cure. Treatment is purely supportive, and when infection develops in the first trimester, because of the high risk of congenital rubella syndrome, some mothers are offered termination. To prevent rubella infection in pregnancy, we vaccinate women prior to becoming pregnant. We vaccinate against rubella with the MMR vaccine, and this is a live attenuated vaccine, so it's never given during pregnancy. So at the first prenatal visit, one of the tests we always do is to screen for rubella antibodies. Mothers who have been vaccinated will have rubella antibodies, and then we know that they are very unlikely to develop the rubella infection in pregnancy. If a mother is negative for rubella antibodies, then she is at risk. Okay, moving on, let's talk about cytomegalovirus. CMV is a herpes virus. It's an example of a DNA virus, and there are several ways by which mothers can become infected. They can be infected through sexual contact, through close contact with an infected individual, for example, a family member, and also through blood or tissue exposure, for example, from a transfusion of blood. Primary CMV infection is usually asymptomatic in about 90% of cases. When it does cause symptoms, it causes a mild febrile illness that's described as a mononucleosis-like illness. This includes nonspecific symptoms like rhinitis and pharyngitis, headache, myalgia, or arthralgia. And then after primary infection, some patients clear the virus from the body, but in other cases, a latent infection occurs, and sometimes this can reactivate later, potentially during pregnancy. When a mother develops infection and transmits it to the baby, her newborn is usually asymptomatic. But the major long-term consequence is sensorineural hearing loss, and it's high yield to know this for your boards. This is the most common consequence of congenital CMV infection. In fact, most babies who develop CMV infection are diagnosed only after they fail a hearing screen, and this leads to a workup for CMV. And cytomegalovirus is the most common infectious disease cause of congenital sensorineural deafness. Besides deafness, other potential findings in a baby with CMV infection are small for gestational age size, microcephaly, hepatosplenomegaly. The blueberry muffin baby rash can be seen in CMV just like it can occur in rubella, and then babies can also develop seizures. On imaging, the classic finding in a baby who has congenital CMV infection is the presence of intracranial periventricular calcifications. These are shown in this image on the screen here. It's not just that there are intracranial calcifications, but the calcifications are lining the ventricles as shown here in the image. This is a classic finding in congenital CMV. It can also occur in other conditions. It doesn't always mean the baby has CMV infection, but it is the classic CMV finding. Screening for cytomegalovirus is not routinely done in pregnancy. Mothers are sometimes tested if they develop a mononucleosis-like illness, or if there are CMV-related fetal ultrasound findings, for example, periventricular calcifications. To establish the diagnosis in the mother, testing is done for cytomegalovirus IgM and IgG antibodies. The ideal way to diagnose a new infection is to test the mother and have her be negative for IgM and IgG, and then test her later and have her convert. That's the surest way to know that a new infection has occurred. If you don't have prior testing that she was negative and you find antibodies, it's hard to know exactly what they mean. The presence of IgG antibodies indicates a past infection, but it doesn't tell you when it occurred. IgM antibodies usually indicate a recent infection, less than 4 months, but it can be longer. Some women have IgM antibodies that persist for up to a year, so the presence of IgM antibodies could indicate cytomegalovirus infection that occurred before pregnancy, not during. And then there is a special test that can be done called an IgG avidity index measurement. This tests how avidly IgG antibodies bind to antigen. If there's a low avidity for binding, this suggests that the infection is relatively recent within the past 4 months. So this can help to localize the time of infection to being within the past 4 months. If you think a mother may have developed symptomatic CMV infection during pregnancy and may have transmitted it to the fetus, the only way to truly know is to do an amniocentesis and send a sample to the lab for PCR testing to identify viral DNA or for a viral culture. And then testing can also be done in the baby after birth. This is done through a sample of blood or saliva sent to the lab for PCR or viral culture. If a mother develops infection during pregnancy, there's no proven maternal treatment that either improves outcomes for the mother or limits transmission to the fetus. In newborn babies, if they are diagnosed, they are treated with antiviral agents. The drugs that are used are ganciclovir or valganciclovir. Okay, moving on, let's talk about herpes simplex virus, which is a sexually transmitted infection. There are two subtypes of herpes virus that cause infection in humans. One is HSV1, the other is HSV2. Most genital herpes infections are caused by HSV2, but they can also be caused by HSV1. When a mother has genital herpes at the time of vaginal delivery, the virus can be transmitted to the baby from genital tract lesions. Importantly, transmission to the baby is usually not transplacental, so the mother can have genital herpes during pregnancy, and the baby is not at risk until the time of delivery if there's a vaginal delivery. Genital herpes infection looks like what's shown on the slide here. It causes vesicular lesions of the genital tract. And when the mother develops genital herpes like what's shown in the picture here, it can be either a primary or a secondary infection. A primary infection occurs when the mother is initially exposed. In this setting, the mother will have genital tract lesions, but HSV antibodies will be negative because she hasn't developed them yet. After a primary infection resolves, the mother can later have reactivation disease called a secondary infection, and in this setting the mother will have genital tract lesions, but the HSV antibodies will be positive because it's a secondary infection and she's already developed antibodies. And you should know that the highest risk of transmission to the baby is if the mother develops primary infection during pregnancy. That's because in the setting of primary infection, there is a low level of antibodies present to help protect against transmission of the virus to the baby. Findings in a newborn of herpes simplex infection include vesicles. These can be found on the skin, often near the eyes or sometimes in the mouth. This is a picture of a newborn with herpes virus infection, and you can see the vesicles along the scalp here and also near the ears. Besides the findings on the skin, the virus can spread to the CNS and it can disseminate to multiple organs, and it can be life-threatening to a newborn baby. Antibody screening for HSV antibodies is often done at the first prenatal visit to determine if a mother has had past exposure. During pregnancy, a clinical diagnosis of genital herpes is made based on the presence of classic vesicular and ulcerated lesions, like what we saw in that picture 2 slides ago. You can confirm the diagnosis with a swab of a vesicle sent to the lab for viral DNA testing by PCR. As an alternative, sometimes viral culture is done, or sometimes direct fluorescent antibody testing is done to identify viral proteins. And then, as I mentioned earlier, HSV antibodies will be negative if it's a primary infection. And the treatment for women who develop eruptions of genital herpes during pregnancy is acyclovir for 7 to 10 days. As an alternative, valacyclovir can also be used. It's a more expensive drug, but it's easier compliance because the dosing is less frequent. After 36 weeks of gestation, women with a history of HSV infection are placed on suppressive acyclovir therapy. This is done for any woman with a history of a genital HSV infection, whether it was before pregnancy or during pregnancy. And then the acyclovir therapy is continued until the onset of labor. Because of the risk of transmitting the virus to the baby in a vaginal delivery, cesarean delivery is often recommended. There are guidelines for this from the CDC and ACOG. They recommend a cesarean delivery in any woman who has active genital lesions or prodromal symptoms of a herpes eruption. This means symptoms like vulvar pain or burning. If these things are present, the guidelines say the woman should have a cesarean delivery after the onset of labor but before the rupture of membranes. In women who have responded well to suppressive therapy and they have no active lesions or prodromal symptoms, the management is more complicated. In some cases, a vaginal delivery can be tried, but often a cesarean delivery is done just to avoid any possibility of transmitting the virus. Our next torch infection is syphilis, which is caused by Treponema pallidum. Treponema is a special form of bacteria called a spirochete, and it's transmitted by sexual contact. There are primary, secondary, and tertiary features of syphilis that you can see in the mother. In primary syphilis, which occurs shortly after infection, there's a special form of genital ulcer called a chancre. Weeks or months later, women develop secondary syphilis, which consists of a maculopapular rash that can occur anywhere on the body, including the palms and soles. And this is a picture on the screen of syphilis on the palms. And then there are a number of potential manifestations of tertiary syphilis, which can occur months or years after initial infection. This includes things like neurosyphilis and aortitis. And so syphilis is very rare in the modern era, but years ago when there was no treatment for syphilis, lots of women had chronic infection. And when they became pregnant, they would give birth to children who had congenital syphilis. And the findings in the baby in congenital syphilis were divided into those that occurred early, before 2 years, and those that occurred later as the child developed. The early findings of congenital syphilis were a maculopapular rash, similar to the rash you can see in secondary syphilis in the mother, also a runny nose, and then these babies were born with lots of abnormalities of their long bones. Usually it involved the legs, and there were many different abnormalities that could occur. As the child grew, other findings would become evident in children with congenital syphilis. Some of these involved the ears and nose. A classic finding was the saddle nose. This was caused by the absence of a nasal bridge that's shown in this picture on the screen here. Children could also develop hearing loss and deafness. Children with congenital syphilis had a number of abnormalities of the teeth. Hutchinson teeth were notch, peg-shaped teeth, and then Mulberry molars were molars that did not develop normally. And then in the legs, many children with congenital syphilis had bowed legs. These were called saber shins. And all of these findings were related to scarring and gumma formation. Women are universally screened in the first trimester for syphilis. This is done through serologic testing. There are two types of tests for syphilis. So-called non-treponemal tests include the RPR and VDRL test, and then treponemal tests include the FTA-ABS test. Usually a non-treponemal test is done for screening, and then if it's abnormal, a treponemal test is done for confirmation. The treatment in the mother, if she develops clinical evidence of syphilis in pregnancy, is with penicillin. For primary or secondary syphilis, the treatment is a single dose of penicillin G, 2.4 million units, as an intramuscular injection. For tertiary syphilis, the treatment is 3 doses of penicillin G. Next, let's talk about parvovirus B19. This is a virus that can be found in the respiratory secretions of infected persons. In children, it often causes outbreaks of Fift's disease. This is where the children have a slapped cheek appearance like what's shown in this boy on the screen here. When adults have infection with parvovirus, they often get arthritis. This can involve the hands, wrists, knees, and ankles. And the important thing to know about parvovirus B19 is it infects red cell progenitors in the bone marrow. In normal individuals, this can cause a very mild anemia that's usually asymptomatic. But in patients who have chronic anemia, for example sickle cell anemia, they can develop a severe anemia if they are infected with parvovirus B19. The fetus is especially vulnerable to B19 for a couple of reasons. First of all, fetal red cells have a shortened half-life, and the fetus has an expanded number of red cells, so it needs to produce more. In addition, the fetal immune system is immature. So for this reason, infection of the baby with B19 can lead to severe anemia in the baby, and this can lead to miscarriage or fetal death. Now luckily, most intrauterine parvovirus infections cause no harm to the baby. But when they do cause harm, some of the things that can happen include fetal loss if it's early in pregnancy, and if the infection occurs after 20 weeks, the classic consequence of B19 infection is hydrops fetalis. This is a picture of a baby with hydrops fetalis on the screen here. It gets this name because there's fluid accumulation. These babies have ascites, pleural effusions. They can also have pericardial effusions. And this is really a finding that's associated with any form of severe fetal anemia. Immune-related hydrops can occur if there's an Rh mismatch between the baby and the mother. But then there are many non-immune causes of hydrops fetalis, and one of the important ones is B19 infection. The diagnosis of B19 infection in the mother can be made through antibody testing. Maternal IgM antibodies to parvovirus indicate acute infection. They're usually positive 10 days after exposure, sometimes prior to the onset of symptoms. So if a mother knows she was near someone who had parvovirus infection, she can be tested. The most sensitive test to truly know if the baby has B19 infection is an amniocentesis for B19 DNA, and this can be done if the baby is displaying signs and symptoms of severe anemia. If women are infected in the first half of pregnancy, the management is simply reassurance. There's no proven risk of anomalies, and there's a small risk for fetal loss. After 20 weeks, women who are infected with parvovirus have weekly ultrasounds to monitor for evidence of hydrops. In addition to looking for fluid accumulation, you can do a Doppler assessment of the baby's middle cerebral artery and measure the peak systolic velocity. This velocity gets very high when the baby has anemia. And then if there's evidence that the baby has infection and anemia from parvovirus, the baby can be treated with intrauterine red blood cell transfusions. And then our last torch infection is the varicella zoster virus. This is another herpes virus infection. Primary infection with varicella causes chickenpox. It can reactivate years later and cause herpes zoster, otherwise known as shingles. And if the mother develops chickenpox, in other words primary infection in the first trimester, this can lead to fetal infection. Now in modern practice this is rare because most women have been vaccinated for varicella, and importantly the risk is only if the mother develops chickenpox. If the mother develops herpes zoster, this does not impact the baby. So as I said, newborns will have clinical features of varicella infection only if there was a maternal primary infection during the first trimester. Findings you can see in the baby include a vesicular rash or scarring. This is a picture of a child with chickenpox, and babies born to mothers who have varicella infection can have a similar rash and scars. The virus can involve the central nervous system in the baby, so there can be problems like microcephaly and hydrocephalus and seizures. The eyes can also be affected, and there can be cataracts or nystagmus. And then in some babies, there's atrophy and hypoplasia of the limbs because of varicella infection. And beyond all these things, there are long-term consequences to infection. These children often end up developing learning disabilities or intellectual impairment. The diagnosis of varicella is usually made clinically when a mother develops a rash consistent with chickenpox and she's never been vaccinated or had chickenpox before, and the treatment is with the antiviral drug acyclovir. Sometimes women who are not immune are exposed to the varicella virus during pregnancy, for example, if they come in contact with someone who has chickenpox or someone who has varicella zoster infection. When this happens, they can be treated with varicella zoster immune globulin. This is called Varzig. This is not indicated in women who have been vaccinated for varicella. It's only for non-immune women who have a definite exposure. I'll finish with this one slide on TORCH screening. So in another video, I talk about standard prenatal screening. But in terms of TORCH infections, it's standard at the first prenatal visit to evaluate a woman for rubella, varicella, and syphilis. For rubella and varicella, you check for antibodies. These should be present if the woman has been vaccinated. And for syphilis, usually a non-treponemal test is done, either RPR or VDRL, and this should be negative. Beyond rubella, varicella, and syphilis, there is additional TORCH testing that can be done, but this varies by practice. So some providers will check for antibodies to toxoplasmosis, HSV, B19, or CMV, but these tests aren't universally performed in all pregnant women everywhere. And then always remember that rubella and varicella are live vaccines, so immunization is not done during pregnancy. If a woman's rubella and varicella antibody screen is negative, then you simply monitor her during the pregnancy, and she should be vaccinated after delivery of the baby. And that concludes our module on TORCH infections.